Once upon a time, life
okay.
used to be a Puritan
We are
process,
covering it.
and medicine used to be the science and art of healing. The medical profession was meant only for the few blessed ones, people with a passion to heal, working to earn something priceless, good karma.
We are ready.
So,
Good morning, Dr. Hiremath.
We are here in Ruby Hall, Pune, and I'm sure you all are enjoying the Lucknow hospitality, and we are really proud to be transmitting to this very prestigious meeting of India.
Thank you very much, and good
Can
morning
you go to
from
run
Lucknow.
one? So this
You can hear me, right?
with me is my colleague Dr. Makhale. Yeah, very
Yeah,
well.
Rajesh.
Okay.
Yes, Ramesh.
And Dr. Gaurav Ganeshwala. So we have this left main case.
To either color. Huh?
Guru, you have a mic?
Okay. No, you don't.
So this lady is 63-year-old,
First slide. Yeah.
and the important thing is the weight is only 39 kilos. She's diabetic. Then she's hypertensive too. Recent admission for ACS, but this was not a simple ACS. She was in heart failure, and she took almost 1 month to recover. During this time, her creat had gone up. Even now, the creat is 1.2. The left ventricle overall is compromised, but wall thickness is preserved in the LAD territory. There is mitral regurg, which is about moderate. And this is what we have for you. Can you come to today's picture, first picture? The left is dominant circulation. Are you able to see the images? Can we go to the images?
Not yet.
The right is non-dominant, so
Show fluoro.
we won't have show pictures for you.
Show fluoro.
Now we can see.
So this is a 7 French EBU. We generally like to take a long sheet, as you can see there, because it gives you a lot of pushability under complex situation. And you can see here the bifurcation at the distal end. Left main is showing a critical disease. Next picture. The left LAD epicranial shows sizable length of the disease, almost coming up to the third septal branch. And in LAO caudal, you can see angle which is quite narrow. In addition, the circumflex is bending on itself as it goes beyond first OM. And as you can see, it's a very dominant circulation. Can you show the previous view again? In this, you can see the circumflex circulation too, a very big dominant circulation. With all this background, the responsibility is tremendous that we are quick. We don't take any steps which is going to cost time, contrast, and so on.
And a history of CVA in the past.
And she also has a history of CVA in past. So let's go to the, can you tell us if you have any thoughts as to how we should do this case?
Thank you.
Can you come
Thank
back?
you, Dr. Hiremath and Dr. Makhale. A very nice case. I'll start off actually saying that our panelists, our chairpersons today are Dr. Eve Luwa, Dr. Sharon, Dr. Michelle, and I'll start off with the Eve. How would you approach this left main coming from that end to this side?
I think with the risky surgery, this will be a real option, and two stent strategy should be the initial approach. I think so.
Two-stent strategy because of circumflex dominant.
Yes.
And how would you approach those two stents? What type of two-stent technique?
I think angle is not that wide.
Show LO caudal.
Culotte
LO caudal.
or DK crush, if it can be done, I think that will be better choice in this situation.
मॉनिटर थोडासा असा कर म्हणजे गौरवच राहील.
First of all, I'm not convinced that proximal LED is hemodynamically significant. So I think we have to test with FFR on LED. Of course, it will be difficult because, as you know, when you are a tight lesion on the other branch, maybe falsely high. So
फिरो.
to be pragmatic, I will stand from left main to circumflex with a wire in the LED. I will open with a balloon without dilating really LED, only the struts. And at that time, I will do the FFR to LED. And if the FFR is okay, I won't touch.
Otherwise, if it is positive, you do culotte then.
Culotte or T-stenting.
Show epicranium.
Dr. Michel? Why not surgery is a question, Dr. Hiremath. So, from the panelists here, one question is why not surgery? Number two is go directly for DK versus culotte, one of them, two-stent technique. That Dr. Eve said that first do a stent from left main into circumflex and then do FFR or IFR of the LAD, and then if need be a V-stent or a culotte.
Yeah, in our discussion, we felt the LED was quite important, significant.
So
So
we'll show you the IVUS
plan was to do IVUS to both the circumflex and the LED. So show the next here on the screen.
Yeah, it is.
On the screen.
Show the
next run,
circumflex.
we
IVUS.
put two wires into both
IVUS circumflex.
LED and circumflex.
Play.
And we had to pre-dilate the circumflex mouth with a small balloon, 2O balloon at low pressure, just to get the IVUS probe in. And now we are showing you the IVUS run. So this is a left circumflex to left main IVUS. The distality looks about 3.7, 3.8, and we are coming back. Mind you, this is after the small dilatation that we did. Can you show the ostium again? Come down, come down.
Bring it down. Stop.
Okay. So this is the criticality at the ostial of circumflex.
Yeah,
The calcium still doesn't look as if we need to use a rota there. So we feel we would do with a scoring balloon.
Let's show the IVUS of the LED.
yeah, that's a huge
The
vessel.
LED IVUS was sent without pre-dilatation, and the LED IVUS could not go beyond the initial 2.5 centimeters. So what you're seeing is actually only the proximal and ostial part of the LED lesion.
It shows the 360-degree calcification all around the circle at the distalmost part.
Yeah, I think it appears to
And
be
as we
very
pull back,
significant by minimal lumen area on the LED with the minimal lumen
Pressure.
diameter just being about 2 millimeters or 1.98, I think. So, did you see 360-degree
give
calcification in the left
heparin.
main?
No, left main doesn't have that bad calcification. Okay, okay. Let's do one check angio.
No, why?
No, the pressure is, I'm concerned on that.
1 minute, 1 minute.
Yeah. Yeah.
So just to quickly take you through some steps, go back.
Go back.
Go back. We have two wires on both sides. We decide to stain the distal part of the LED first.
Please show
Go,
the
go,
angio on
go.
the bigger screen.
Okay.
Angio.
Angio on the big screen here.
Okay, now we can see.
No, go here. Okay, epicranial with the wire.
So we
With
use
the
a
balloon.
we use a turn track wire.
So we use a turn track wire, which is a new introduction
there
by
goes.
Abbott.
Atropine will take care of
And I
both.
think we have little experience, but whatever we have, I think it looks a very good wire. This is a 2O balloon, regular balloon used for dilatation as well as sizing. Then we had two
Give atropine and small dose of NORAD, otherwise you can
NC balloon going high pressure, and this is a stain placement. This is a Onyx 27526 placed in position. Go.
Next.
And this is so the distal part of the LED is taken care, and now we can focus on the proximal bifurcation. Next. So this is a 3015 scoring balloon.
Angiosculpt.
Angiosculpt. The way we do it is generally go to about 6, and then step by step from 6 to 12 or maybe 14. And then this is a 30 NC balloon, high pressure, and this is where we are. So this is the last picture we saw. Blood pressure is all right.
Yeah.
We are going to take a 4022 Onyx stent. Now at this stage, we have to make a decision whether to take out the LED wire. For culottes, of course, we will want to take out the wire. You see a little dissection, but that is close to the back end of the LED stent, and I feel the ostium is quite nice. So ostium is not pre-dilated at this stage. So this is what one of the important steps for culottes, that we have not touched the ostium as yet.
Right. So there is a dissection in the osteal circumflex.
So you all agree on pulling out the LED wire?
No.
Yeah.
Yes.
I mean, I don't remove wires anymore. I used to be scared about it in my first year probably, but now I jail my wires. I don't take the wire out at all. My question to you is actually in OM1, would you protect that now since you caused a dissection of the osteal circumflex, and there is a small, but it's, I mean, it's a decent size OM1. Would you protect that?
No, it's not on our thinking list as yet. But let me see, let's see the last picture again.
So one of the predictors of side branch occlusion is a dissection proximal to the side branch involving even up to the ostium. So that's what we see actually, that's what I see at least. I would put a wire into that OM1. I would not remove the LED wire. I agree with you that I'll go ahead and put a stent from the circumflex to into the left main. Any suggestions from
So
you?
even if I'm doing culotte, you don't want me to remove the LED wire?
Dr. Yves Louard from France with a lot of experience on culotte, would you jail the wire or remove the wire?
I jail the wire doing stenting from left main to circumflex. Of course, after that, I will remove the circumflex wire, put it in LED, degel the LED wire, and put it in the circumflex. For me, this is a safer way to be sure that we are not losing a branch.
Right. We jail the wire. That's exactly what we do. Michelle? Dr. Michelle? No. So panelists agree not to remove the wire, but that's you're doing the procedure, so you have to do what you feel comfortable with.
Yeah, I'm going to remove the wire because that is what I'm used to. So this LED wire comes out. Keep it again ready for me. So let's take a picture first.
So I don't jail actually hydrophilic wires. I mean, we are even writing now an article about microembolization of the hydrophilic materials.
We're okay.
Can happen. So I usually jail.
Shall we go into the epicranial view?
Epicranial.
Very good wire to jail.
Actually, we had a turn track in LED. Which we have removed just now.
Contrast.
It's,
All right, let's go. So we are just going to about 4.
Dr. Makhale, what anticoagulation, antiplatelets, and
We
and
come
this
back to
patient
Caudal.
who's 39 kilograms. I mean, in the United States, I would have said that's a typo. You know, it should be 93 kilograms.
yeah. Yeah. As of now, we are given the Plavix.
Deflate quickly. Bus. So we went only to about 5, is it? Okay.
Yeah. Yeah, but it is not fully expanded.
So we are coming back.
Okay.
I would
No.
That's
Okay.
good. That's
Yeah.
good.
Give me that 2O balloon, please. Enough.
6.
So we went to 6. Let's do a pot. 4.58.
Okay, shall we check the OM one that now?
No, it's too early. to
Maybe
check.
we underestimated the amount of calcium there is because the osteal circumflex is not really expanding well, and the IVUS catheter could have just jumped. As we saw that we didn't really see a good capture of the IVUS. It might look like it jumped. In that. So I think what they're doing is very good.
We have used scoring balloon going to about 14 atmospheric pressure. I mean, the IVUS would probably, you are trying to say we could have used a rotablator?
Yeah, no, I'm just looking at a stent.
This is
It is
4.5.
definitely underexpanded in the osteal region, whereas on both in the left
Yes.
vein and in the proximal
Yes.
circumflex, it is well expanded, almost like flare.
Yeah, but we were at very low pressure, around 6.
Right. You can still go up on with the pot. It might be better.
Yeah.
I'm following
So
now
keep a
Akiko.
wire ready now, same wire.
So Akiko Mera from CRF in Colombia, she came up with this nice criteria of 270-degree arc of calcium. You give some points, 0, 1, 2. For less than 180, 180 to 270 is 1 point, and more than 270 is 2 points.
Okay.
And less than 0.5 millimeter thickness of calcium is 0. More than 0.5 millimeters is 1 point.
12.
And also
14, 16.
the length of the vessel calcification, length of the calcification.
Wire
If it is
ready,
more than
please.
5 millimeters, you get 1 point. So anything more than 3 to 4 points, you do rotablation. So I think we have to go into the other room in 2 minutes. But we'll stay with you. I think you're almost about to show us. Good.
Okay, we'll take a picture and then work on the proximal.
Ramesh, we'll
LED.
just show you the latest picture and then you can go.
Yeah, I don't know whether they'll be ready. If not, we'll stay with you until they're ready for us.
Okay, so we'll continue here.
Please continue.
Okay, we are taking a picture.
So OM is preserved
Okay, get the wire, please.
and maybe it is because of the stent design also, because Onyx has got a better access for the side branch accesses. The side windows are bigger.
Freeze and zoom.
I mean, I think the circumflex looks good. The osteal OM1 is okay, but there's TIMI3 flow. I don't think we need to do anything
Sure.
further for that. And now the question is about LAD. Would you still do an FFR-E, Dr. Luwar?
Of course not. This is a tight lesion now.
Yes. So what type of stent you would say? Culotte now.
You can do a culotte, we can also do a T or a tap, depending, which will avoid overlapping of struts. We know that since a desert trial by made in US, you know that overlapping stents
Choose a stent. 3,
is a
5
factor of
into
stent
something.
thrombosis.
Okay,
3.23.
So much of haze in proximal
wire is
LED.
looped.
Still, you will
Get me
prefer
another wire.
FFR before going on to stent.
Another wire, get us cross.
No need. I don't think
Cross it
so.
and it,
As we were talking about it, and I mean the LAD still appears significant angiographically. I think early on, if you wanted to make a decision, you can.
Run the last picture.
Still, provisional stenting, one stent if can do the job, the results long term is still best.
Much better.
After, although decay crush technique is showing better and better results with newer stents. So, but here the disease of ostium and LED is already seems to be significant.
Yes. I think it's a, by definition, it's a two-stent strategy lesion. It's long lesion in the left main, long lesion in the circumflex. And I think you got a very good result in the circumflex. Now you have to just address the LAD. Are you going to go direct stenting for the LAD, or you're going to do any balloon for the ostium now, Dr. Hiremath?
No, we'll pre-dilate.
We have not dilated the ostium at all.
Right.
So I think we have to do a dilatation for sure.
So we'll wait with you for maybe a couple minutes
Okay,
to see
go
you're
on
wiring the
fluoro zoom.
lesion.
Sure.
If you go
So
for a
this is
culotte,
additional
I think it's very
facility we
important to
have.
know that
This
you
is
have to cross towards the LED very close to the carena.
Okay, correct.
If you don't do that, you increase the volume of metal at the carena level, which is not good. Very close to the carena, and when you go back to the circumflex later, you will also to re-enter the circumflex close to the carena.
So you mean in distal cell?
It's distal, is not really distal here, it's carena cell.
Right, carena cell.
A sort of mini tap.
Okay, very good.
Okay.
Safe. Yeah, zoom out.
Go epicranial. Actually, this distal proximal, I think many times we keep arguing. I think only champions can manage whichever strut they want. I think we are happy going through whatever really comes.
Dr. Hiremath?
Yeah, we could guess that.
Yeah, we are back with
So
you.
actually, we tried ballooning the LED wire with the 2O balloon which we had used to pre-dilate, but the balloon cannot cross. So we are now with a 1.5 balloon going towards LED.
तू बघतोयस ना तिकडे?
So now I have a question. When we do the stenting to LED, at least at that stage you remove the side branch wire, because we'll be with 2 layers of stent at that stage.
So Dr. Luward is saying that you can go with the tap, with the minimal protrusion. And in such case, I don't think we need to remove the wire. If it is even completely culotte, then between 2 layers of stents, I would remove the wire. And so it depends upon how much protrusion you're going to have the LED stent into the left main.
Actually, the circumflex stent is coming back all the way to the
Left
ostium.
Right.
So it's, I guess we are going to have a minimal overlap in the left main with these 2 stents.
Yeah. I think tap is good technique with in this angle.
So here we are with the 1.5 balloon crossing easily.
Come back a little on the.
There you go, 1 is 15. Give that 2.5 balloon. NC. 2.5 NC you have.
You have a cutting balloon too, right? Angiosculpt?
You want us to use angiosculpt on that?
Yeah,
I mean, there is calcium all right, so.
I thought there was a lot of calcium in the osteal LED, right, on IVUS?
All right. Yes.
I mean, after you do the 2.5 NC, you can do a angiosculpt as well.
Yes, we'll do the angiosculpt at that stage. So keep the angiosculpt ready.
Negative.
We have to size it. No?
Yeah.
Would you do IVUS at this point?
NC, this will be
It didn't do the IVAS.
I won't do, no,
No, I
certainly
think
not. No.
first we'll work on.
All right.
We have the
So
diameter
what
of
is the idea of
circumflex.
doing IVUS at
We have
this
the
stage?
diameter of distal LED, so we can know the diameter of left main. It's not
Right.
that difficult.
Dr. Saran, would you do IVUS at this point? I mean, to see the size of the left proximal LED, to put whether if you think you might be choosing.
Distal LED is well seen.
Get with the box.
Right.
2.5.
The sizing is
She's
not
vomiting.
the issue at the moment in my mind. Three will be all right.
Yes.
To expand it to.
Is she vomiting?
And I,
Huh?
and actually, we have done the LED stenting, LED IVUS in the beginning.
Hey, get me another balloon.
2.5 NC, please.
Would you remove the circumflex wire at this point of time? Eve?
Yes.
I don't think it's
as we
necessary, but
get close to
we don't use it now,
the
so you can remove if you want.
Yeah.
left.
So if there is a question about wire wrap, I would remove the circumflex wire at this point of time because you've already stented left main into LED. Yes. Right. Absolutely, I
Yes.
agree. You have to
We are changing
optimize.
the balloon, so let's see.
Dr. Hiremath, we haven't optimized the osteocircumflex, so if you once you have done it, I think we could have removed the circumflex wire, but I think
No,
keep
we
it
did.
you did?
No, we did ostial circumflex was optimized with
Oh.
3.5 NC balloon going to 2830.
Yeah, when we were off screen at that time.
Right. We are off screen. Sorry. Yes.
So if this balloon doesn't go, I will pull out the circumflex wire.
It's a new balloon.
Honestly, the circumflex wire now is,
Yeah.
yes,
Yeah. If it doesn't go, I would
it's
remove the wire.
a little bit redundant, and we could.
Okay.
LED wire advance kar. Okay, let the circ wire come out.
So I'm taking out the circ wire. I come to RAO coil. So we are actually going through the stent strut.
Yeah, I think you can
we go
start
to
right there.
epicranial? Let's
and
adjust the wire distality.
you
Yeah,
can-
by the nose cone we can.
yeah. I think once you open up that cell, you will be able to advance
Okay,
it
come
further.
back to RAO caudal. RAO caudal. No, actually the ostial LED is not pre-dilated. So if this balloon loses its profile,
Yeah.
okay,
There you
yeah,
go.
okay,
And now this
okay,
is. We'll do
Okay,
one
go up.
sizing also.
yeah, no, go up quickly, go quick.
Yeah, that balloon length looks good.
10, 12, 14, 16. Okay. So we are going to size this in this view only.
Yeah.
So we propose to put the
18.
LED stains from somewhere here,
Yeah.
or maybe a couple of millimeter back.
I think
So
that looks
keep the
good.
stent ready.
3.5, 22.
Sizing.
22.
Sizing. We are doing the sizing at this stage.
So one epicranial.
Okay, epicranial.
Yeah. So we have only 1 minute with you. If you can show us the stent.
Circumflex stent is still not optimally dilated after the ostia.
Yeah, we'll do it at the time of the kissing. And
No, we can do it now. No, we can do it. This is a 2.5. The stent is 2.75.
no, he's talking the circumflex stent.
So circumflex distal we have done. Circumflex we have done. Okay, go.
So we'll go to the other lab and we'll come back to you if we have time, but you have shown us excellent way of doing
Okay,
this
what-
complex
sure.
left main PCI. Thank you very much, Dr. Hiremath and Dr. Makhale.
Thank you.
And Dr.
Really
Gaurav.
enjoyed.